Good morning. Today we are going to study the functional areas of cerebrum. So each cerebral hemisphere consists of an outer layer of grey matter that is forming the cerebral cortex and an inner mass of white matter. This is different from the spinal cord. When we learned about the cross section of spinal cord, there is an inner core of grey matter, that is the edge-shaped grey matter, and a peripheral zone of white matter. But for the cerebral hemisphere, it is different. The grey matter is on the outside and the white matter is on the inside. And in addition to all this, there is a large mass of grey matter that is embedded in the basal part of the white matter, which are collectively called the basal ganglia or the basal nuclei. And the cavity of the cerebral hemisphere is formed by the lateral ventricle. So, in 1909, a neuroanatomist called Brodmann, he classified the cerebral cortex. He divided the cerebral cortex into 47 functional areas. So there are about 47 functional areas, and these functional areas can be of three types. That is, either they are motor areas or sensory areas or associative areas. Motor areas are concerned with motor function and they give origin to projection fibers from the cerebral cortex. Whereas sensory areas have sensory function and they receive the afferents from the thalamic nuclei. And association areas have associative or integrative functions. So, we are going to learn the functional areas lobe-wise. That is, we are going to learn the functional areas in the frontal lobe first, then the parietal lobe, then the temporal lobe and occipital lobe. Okay, so now we are going to learn about the functional areas in the frontal lobe. So, the first functional area is area number 4, Brodmann's area number 4, that is the primary motor area. So, this is the primary motor area that is located in the Prefrontal Gyrus. But a part of it extends also into the medial aspect onto the anterior aspect of the paracentral lobule. So, this is the paracentral lobule. We have studied the space that is enclosed around the central sulcus. So, that is your paracentral lobule. And the anterior part of paracentral lobule, you have this motor area, that is the primary motor area, area number 4, is extending also into the medial aspect. So, the function is it controls the muscles or the voluntary movements of the opposite side of the body. So, it contains fibers like corticospinal and corticonuclear fibers. Our human body is represented in an upside down manner in the prefrontal gyrus. So that the pharyngeal region, the tongue, all this is represented in the lowermost part. This is the face that is represented above that, and then we have the hand, the rest of the upper limb, the trunk, the thighs you can see, and you can see the leg, perineum and the foot. All these are represented in the medial aspect. Okay, in the medial aspect, the leg, perineum and foot is represented. So, this is how it is represented. This is called the inverted motor homunculus. What is it called? It is called the inverted motor homunculus. It is in an inverted manner. And also you can see each part has a disproportionate representation in the precentral gyrus. That is, the area of cortex controlling a particular movement, it is not proportional to the size of the individual part, but it is proportional to the skill involved in performing the movement. So, it is proportional to the skill involved. So, you can see the face, the hand, the tongue, all these things have greater representation because humans can do a lot of skilled movements with the hands, with our facial muscles, with the tongue, with the muscles of the larynx. We are doing a lot of functions. So, these have greater representation than the remaining, the trunk, the thighs, all this have no much of skilled movement. So, they are given smaller representation, whereas the face and the hand is given larger representation in the body. So, coming back, so that is the primary motor area or area number 4. Next area that we have to study is area number 6. Area number 6 is called the premotor area. So, that is the premotor area. So, that is also extending into the medial aspect. So, you can see the premotor area will also extend into the medial aspect. This is the premotor area. It is seen in the posterior part of the superior, middle and inferior frontal gyrus. So, this is the superior frontal gyrus, this is the middle frontal gyrus and this is the inferior frontal gyrus. So, in this, the posterior part of the frontal gyrus, you have the premotor area, that is area number 6. And its function is helping in the planning and the programming of the motor function. So, it controls the extrapyramidal system. So, it contains corticonigural, corticorubral, corticoolivary fibers. Motor area does the motor function. The programming is done in the premotor area, that is area number 6. Another area is area number 8, that is Brodmann's area number 8, that is called the frontal eye field. So 8 is called frontal eye field. Frontal eye field. So that is represented in front of the premotor area in the posterior part of the middle frontal gyrus. So it is in the posterior part of the middle frontal gyrus, and its function is it controls the horizontal voluntary conjugate movements of the eyeball. So it helps in the conjugate movements of both the eyeballs. So that is the frontal eye field, that is area number 8, that is located in the posterior part of middle frontal gyrus. Then the next one is prefrontal area. So we have area number, that is area number 9, area number 10, 11 and 12. So 9, 10, 11, 12, this is the prefrontal area. That is a prefrontal area. So though it is seen in the superlateral aspect, it is also extending into the medial aspect. So 9, 10, 11 and 12. It is also extending mostly into the medial aspect. This is the medial frontal gyrus. It is extending into the medial frontal gyrus. The area number 9, 10, 11 and 12. And it is called the prefrontal area. So it is rostral to the premotor area. Okay. And area 12 is mainly seen in the orbital surface. So the prefrontal area controls the personality, the behavior of the individual, the emotions, concentration, attention and judgment. So all these things are controlled in the prefrontal area. The next area that we have to study is area number 45 and 44. So area number 45 is seen in pars triangularis. This is the pars triangularis and this is the pars opercularis. So pars opercularis is area number 44 and pars triangularis is area number 45. And this is the motor speech area. This is the motor speech area. It is also called the Broca's area. And this is seen in the dominant hemisphere. So we know of the two cerebral hemisphere, one of the hemisphere will be the dominant hemisphere, which determines our handedness and all, if you are right-handed or left-handed. So on the dominant hemisphere, in the pars triangularis, we have area number 45 and pars opercularis, we have area number 44. So this is collectively called the motor speech area, the Broca's area. It helps in the speech expression or the vocalization. So it brings about the formation of words by the connection with the adjacent primary motor area. So we have the adjacent primary motor area. So with the help of the connections with that, it helps in formation of the words. So if this Broca's area is affected, if there is a lesion in the Broca's area, what will happen? We will lose our ability to produce speech. Okay, so that is called motor aphasia. So that will be motor aphasia if the Broca's area is affected. So we will not be able to produce speech. So the person can understand the language. He knows what he wants to say, but he is not able to say it. He is not able to express it in words. He can think about the words. He can even write it down, but he is not able to say it. When another person speaks to him, he is able to understand it, but he is not able to speak. So even though there is no paralysis of the muscles of lips, the tongue, the vocal cords, all these muscles are intact, the patient is not able to speak when the Broca's area is affected. So spoken language will be slow and it will be non-fluent. The fluency will be decreased when there is a lesion in the Broca's area. Okay, so that is the vocalization or the speech expression is done by the Broca's area, that is motor speech area, area number 45 and 44. Now, so that is about the functional areas in the frontal lobe. Now coming to the parietal lobe. The first area that we have to study is area number 3, 1 and 2. This order is very important. This is the postcentral gyrus. In the postcentral gyrus, area number 3 is anterior, then area number 1, then area number 2. So 3, 1, 2, that is the order. And this is the primary sensory area. Okay, so this is the primary sensory area. You know the central sulcus, on either side of the central sulcus, we have the precentral gyrus, postcentral gyrus. Precentral gyrus is primary motor area, postcentral gyrus is primary sensory area. So central sulcus acts as a limiting sulcus. So that we have already covered. Primary sensory area is located in the postcentral gyrus and it is also extending into the medial aspect, into the posterior part of the paracentral lobule. The function is, it helps in the sensory perception of the opposite half of the body. So that is, it helps in perception of both exteroceptive and proprioceptive impulses. Exteroceptive impulses is the touch, pain, temperature, all those impulses, and proprioceptive impulses are joint sense, position sense and the 2-point discrimination, and it receives the projection fibers from the thalamus, because the thalamus is the primary sensory relay station, and from there the fibers are coming to the primary sensory area, the postcentral gyrus, that is area number 312. Here also the opposite half of the body is represented in the upside down manner. The pharynx and tongue will be represented below, then we have the face, then we have the thumb, the hand, the rest of the upper limb, the trunk, and the leg, foot and perineum is represented in the medial aspect. And here also the area of cortex is assigned for a particular part is not proportional to the size but to the functional significance. So our thumb, we have a lot of sensory perception in our thumb, all our fingers, the lips, the tongue, all these have larger representation in the postcentral gyrus. So this is called sensory homunculus. So this is called the sensory homunculus. So that is how it is represented. Then comes the next area, that is the sensory association area. So that is area number 5 and 7. Area number 5 and 7 is called sensory association area. This is in the superior parietal lobule. So the primary sensory area is the area number 312. The further processing of the sensory input takes place over here in area number 5 and 7 for the perception of the genital senses. So that is the next sensory Brodmann's area, 5 and 7, sensory association area. The next area is area number 40. That is located in the supramarginal gyrus, and that is higher association area for the somatic senses. That is a higher association area. So we have the primary sensory area, then we have the sensory association area, and we have a higher association area for somatic senses. And what does this do? It recognizes the familiar objects with the help of touch and proprioception. That is, if a person is able to close his eyes and you give an object to the person and he is able to perceive it without seeing, he is able to feel the object and able to identify the object. That is done by this area, area number 40, supramarginal gyrus. So this method in which the patient is able to perceive the things with the help of the touch is called stereognosis. So this property is stereognosis. So if there is a lesion in this region, area number 40, what will happen? There will be a stereognosis, or there will be tactile agnosia. But as the patient closes his eyes, given object he is not able to identify, that means it is tactile agnosia, or it is also called a stereognosis. So that is area number 40. So it is a higher association area. Then the next area is area number 39. This is area number 39. It is located in the angular gyrus. Here, this area, it stores the visual images and recognizes objects by sight. So if there is a lesion in this area, what will happen? There will be word blindness. That is, the patient is not able to, he cannot read and he cannot write. Okay, so that is alexia and agraphia. So that is called alexia and agraphia. Word blindness. Okay, so that is area number 39 if it is affected. Okay, so that is the angular gyrus. So these are the sensory areas in the parietal lobe. So we have area number 312, that is the primary sensory area. Then we have the sensory association area, that is 5 and 7, that is located in the superior parietal lobule. Then in the supramarginal gyrus we have area 40, that is higher association area, that is helping in stereognosis. Then area number 39, that is the angular gyrus, and that is helping in using visual images to identify an object. So if it is affected, there will be alexia and agraphia. Then coming to the functional areas in the temporal lobe. So the first area is area number 41. Area number 41, that is the primary auditory area. It is located in the anterior transverse temporal gyrus. That is the Heschel's gyrus. Before we have studied the Heschel's gyrus, that is the anterior transverse temporal gyrus. So it is located in the superior part of the superior transverse gyrus. So this is the superior temporal gyrus, this is the middle, and this is the inferior temporal gyrus. The superior surface of the superior temporal gyrus, anteriorly, you have the Heschel's gyrus. That is in the floor of the posterior ramus of lateral sulcus, you have the Heschel's gyrus. So that is primary auditory area. So what is the function of the primary auditory area? The primary auditory area receives the input from the medial geniculate body through the auditory radiation. So auditory pathway, we have the medial geniculate body. From the medial geniculate body, the input is going to be received through the auditory radiation, and it helps in the sense of hearing. It also helps in detecting the direction from which the sound has originated. So that is the source of the sound identified with the help of the primary auditory area. That is area number 41. Then we have the auditory association area. So area number 42 is just behind the area number 41. That is the auditory association area. So this is the auditory association area. So that is located in the posterior transverse temporal gyrus. That is the area behind area number 41, and it helps in identifying the sounds from the past memory. Sound, we know the sound of a lion from past memory. We hear it now. We are able to identify that it is a sound of a lion. So that is the auditory association area, area number 42. Then we have behind area number 41 and 42, there is another area, that is area number 22. This area number 22 is also called Wernicke's area. What is it called? Wernicke's area. It is the rest of the superior temporal gyrus behind area number 41 and 42. This area is the higher auditory association area. So it is a higher auditory association area. Area number 22, it is also called Wernicke's area. It helps in interpreting the sound and comprehension of spoken language. So we are able to understand because of the Wernicke's area. So if there is a lesion in the Wernicke's area, what will happen? There will be sensory aphasia. So Broca's area will cause motor aphasia, whereas Wernicke's area will cause sensory aphasia. So that is, the patient is not able to understand spoken and written words. But since the Broca's area is intact, the speech will be fluent. But he is unaware of the meanings of the words he uses. So he is able to speak fluently because there is no problem in expression. Vocalization is okay, but he is unaware of the words that he is using. So he will use incorrect words or even non-existent words. Okay, so if he uses non-existent words, that is called jargon. So that is the problem if the Wernicke's area is affected. So he will speak fluently, but he may use wrong words. So that is sensitive. He is not able to understand what you are saying. Okay, but he is speaking back. All nonsense. So that is the Wernicke's area, area number 22. So that is the functional areas in the temporal lobe. Okay, so now before we move on further, another thing I wanted to say was Broca's area and the Wernicke's area are connected to each other by a fasciculus, and that is called the arcuate fasciculus. There are 4 speech centers in the dominant hemisphere. That is, the first one is Broca's area. Broca's area is area number 44 and 45. Area number 44 and 45. 45 is located in the pars triangularis. 4 is located in the pars opercularis. That is a Broca's motor speech area. So that helps in speech expression. The next area is the Wernicke's area. Wernicke's area is area number 22, and that helps in the comprehension of language. Another speech center is the area number 40. That is in the Supramarginal Gyrus. That is helping in stereognosis. That is, by the touch, you are able to identify the objects. And then next one is area number 39. Area number 39 is in the angular gyrus, and that helps in identifying the objects by visual cues. The last 3 areas, area number 40, 39 and 22. These 3 areas together are called this is the sensory speech area. This is the motor speech area, and this is the sensory speech area. So we have area number 40, 39, 22. They are in structural continuity, and so they are called the sensory speech area. And they receive inputs from the hearing, vision, touch and proprioception. It is processed in area number 22. It is processed in the Wernicke's area, and it is projected to the Broca's area. So this is projected to the Broca's area through the arcuate fasciculus. So what happens if there is a lesion in all these structures? Area 22. Area 22 is affected means what will happen? There will be sensory aphasia, right? Wernicke's area is affected, there will be sensory aphasia, or there will be word deafness. It is also called word deafness. So the patient is not able to comprehend what you are speaking. He is not able to understand what you are speaking, but he is speaking back to you fluently. Okay, he is using all sorts of non-existent words or incorrect words, and he is able to speak fluently. So the speech will be fluent. Okay, so that is when you get Wernicke's areas affected. What about area 39? It is located in the angular gyrus, and if that you need visual cues for identifying this object. So if there is a lesion, it will cause word blindness. There will be word blindness, and you have an inability to read and inability to write. So that is alexia and agraphia. If area number 40 is affected, that is in the supramarginal gyrus, you will get stereognosis or tactile agnosia. And if Broca's area number 44, 45 is affected, Broca's area is affected, what will happen? You will get motor aphasia. What is motor aphasia? Motor aphasia is when you are not able to speak. You know what you want to speak. You want to speak, but you are not able to speak. Okay, and there is no muscle paralysis also, but you are not able to speak. So the speech will be slow and it will be non-fluent, right? So we have different types of aphasia. Aphasia is some problems with the speech, right? If we get motor aphasia, what will be the problems? What about the fluency? What about the comprehension of language? Repetition of words. If motor aphasia is there, the fluency will be affected. Comprehension is okay. Wernicke's area is okay, so comprehension you are able to understand, but you are not able to speak. Repetition will also be affected. If there is sensory aphasia, that is, if Wernicke's area is affected, the comprehension is affected, right? But the speech will be very fluent. You will use a jargon of words, you will use nonsense words, but the fluency will be normal, repetition will be affected. Then what is conduction aphasia? There is something called conduction aphasia. That is, if the arcuate fasciculus is affected, there is a lesion in the arcuate fasciculus, comprehension is okay, the Wernicke's area is okay, so the fluency is also okay, but the repetition will be affected. Then there is another entity called global aphasia. If there is global aphasia, all the speech centers are affected. All these speech centers are seen in the dominant hemisphere. Broca's area, Wernicke's area, everything is the arcuate fasciculus, everything is compromised, means everything will be affected. The fluency will be affected, comprehension will be affected, repetition will be affected. So this is about aphasia. Aphasia you learn in detail when you go to medicine. This is a very, very important topic. So we have completed the functional areas in the frontal lobe, parietal lobe and the temporal lobe. Now we have to learn the functional areas in the occipital lobe. So for occipital lobe, we have the primary visual area, that is area number 17. Area number 17 is over here, okay, that is located in and around the posterior part of calcarine sulcus is the post-calcarine sulcus. The primary visual area is over here, area number 17. It is also called striate area. It is also extending into the medial aspect. So this is the calcarine sulcus. So this is area number 17. This is area number 17. It is also extending into the cuneus. You remember this is triangular area. The triangular area is the cuneus, and between the collateral sulcus and between the calcarine sulcus we have the lingual gyrus. So this is the lingual gyrus. So here you have the area number 17. That is the primary visual area. It helps in the sense of vision. It receives the primary input from lateral geniculate body via the optic radiation. The visual path we will be learning in detail later. So from the lateral geniculate body via the optic radiation, the impulse is going to the area number 17, also called the striate area. Area number 17. Then we have the visual association area. So we have the primary visual area, then we have the visual association area. So visual association area is area number 18 and area number 19. 18 is parastriate area. 19 is called the peristriate area. Where is it seen? It is seen around the area number 17. So this is area number 17, this is area number 18 and this is area number 19. Okay, it is also seen in the medial aspect. In the medial aspect around the area number 17 you get the 18 and around that you get the 19. So in the walls and the floor of the lunate sulcus you get the parastriate area, that is area number 18, and you get the peristriate area, that is area number 19 away from the lunate sulcus. So what is the function of visual association area? We are able to correlate with past visual experience and we are able to recognize the objects. So that is the function of visual association areas. So we can see we have already studied the calcarine sulcus. The post-calcarine sulcus is an example for axial sulcus. So for the visual area it is forming the axis. So that is the post-calcarine sulcus. This is the example for axial sulcus. Whereas lunate sulcus is an example for operculated sulcus because it is separating the area number 17 from area number 19. It is separating the striate area from the peristriate area, and within the walls of the lunate sulcus within the walls and the floor, you will get the parastriate area, that is area number 18. So that is about the lunate sulcus, which is an example for operculated sulcus. Now coming to the medial surface. So we have completed everything in the supralateral surface. Coming to the medial surface, we have studied area number 4, that is primary motor area, has extended into the anterior part of paracentral lobule, and the primary sensory area number 312 has also extended to the posterior part of the paracentral lobule. So you remember the paracentral lobule. The paracentral lobule is the center for micturition and defecation. It controls the sphincters of the urinary bladder and anal canal, so that is why it is a center for micturition and defecation. And the medial frontal gyrus, you get area number 9, 10, 11 and 12. It is extended. Also the visual area number, the striate area number 17, the primary visual area, and the visual association area number 18 and 19 is also extended to the medial aspect. Now in the uncus we get area number 28. So in the uncus we get the area number 28, that is the primary olfactory area. So these are the important areas in the medial aspect. So coming back, we'll just revise quickly. In the frontal lobe, we have Brodmann's area number 4, that is the primary motor area. Area number 6, that is the premotor area, that is in the posterior part of the superior, middle and inferior frontal gyrus. We have the frontal eye field, that is just in front of the premotor area in the posterior part of the middle frontal gyrus. We have the area number 8, that is frontal eye field, that controls horizontal conjugate eye movements. Then we have area number 9, 10, 11 and 12 from above downwards in the anterior part of the frontal lobe, extending into the medial frontal gyrus, mainly in the medial frontal gyrus, and that is the prefrontal area. Then we have area number 45 and 44, that is Broca's area, motor speech area. Then we have in the parietal lobe, we have area number 3, 1 and 2. Area number 3, 1 and 2, that is primary sensory area. The sensory association area is area number 5 and 7, that is located in the superior parietal lobule. Then in the supramarginal gyrus, we have area number 40, that is higher association area, which helps in stereognosis. Then we have the angular gyrus, we have area number 39, that is helping in the recognition of objects by the visual images. And then we have area number 22. In the temporal lobe, we have the posterior transverse temporal gyrus, we have area number 22, that is the Wernicke's area, that helps in comprehension of language. Then we have the primary auditory area is area number 41. Number 22 is the higher association area, and the auditory association area is the area number 42. So that is about the temporal lobe. And then we have in the occipital lobe, we have area number 70, is the striate area, that is the primary visual area, and the visual association area is area number 18 and 19. And 18 is parastriate and 19 is peristriate area. In the medial aspect, the primary motor area, primary sensory area, then the prefrontal area, all these have extended into the medial aspect. Also the visual area has extended in the medial aspect. The paracentral lobule is present in the medial aspect, and it is the center for micturition and defecation. And area number 28 is present in the uncus, and it is a primary olfactory area. So that is about the functional areas in a nutshell. Coming to the blood supply of the cerebral hemisphere. The supralateral surface, the main artery of supply is the middle cerebral artery. So this is supplied by the middle cerebral artery, and this is the small strip along the supromedial aspect is by the anterior cerebral artery, and this posterior part is supplied by the posterior cerebral artery. So the main artery of the supralateral surface is middle cerebral artery. So if middle cerebral artery is affected, what are the features that we are going to see? We have seen the primary motor area and the primary sensory area will be affected. So there will be contralateral hemiplegia and hemianesthesia. But the leg and foot is spared because leg and foot is represented in the medial aspect. But there will be contralateral hemiplegia and anesthesia. Then coming to the speech centers, we have the Broca's areas over here, the Wernicke's areas over here. So all these centers will be affected, and there will be aphasia. In a right-handed person, if the left dominant hemisphere is affected, there will be the Broca's area, Wernicke's area, the arcuate fasciculus, all this will be affected, and it can result in aphasia. So these are the features of middle cerebral artery is affected. Coming to the medial aspect, the main artery of this region is anterior cerebral artery, The temporal pole alone is supplied by the middle cerebral artery, and the inferior aspect of temporal lobe and the occipital lobe is supplied by the posterior cerebral artery. So the main artery of supply over here is the anterior cerebral artery. So what happens if there is an occlusion of the anterior cerebral artery? First, the primary motor area extends into this region around the paracentral lobule. Also, the sensory center also extends. Area 312 also extends into this region. So this area represents the leg and foot. So there will be weakness or paralysis of the muscles of the leg or foot of the opposite side. So there will be monoplegia. So there will be loss of sensation also. So there will be paralysis of muscles and loss of sensation of the leg and foot of opposite side. Then also the paracentral lobule is affected. So we know the paracentral lobule is the center for micturition and defecation. So micturition and defecation will be affected. That is, the sphincters of the urinary bladder and anal canal will be affected when there is anterior cerebral artery occlusion. Also the prefrontal region, this is the medial frontal gyrus. Here we have the prefrontal area, that is area number 9, 10, 11 and 12. So when this is affected, there will be personality changes as well. So these are the features that we see in anterior cerebral artery occlusion. There will be monoplegia, that is weakness or the paralysis of the muscles of the opposite leg and foot, the loss of sensation of the opposite side leg and foot. Then there will be micturition and defecation and personality changes. So that is when there is anterior cerebral artery occlusion. Coming to the inferior surface, a small strip of the orbital surface is supplied by the anterior cerebral artery. The rest of the orbital surface and the temporal pole is supplied by the middle cerebral artery, and most of the area of the tendoral surface is supplied by the posterior cerebral artery. The main artery of this inferior surface is the posterior cerebral artery. If there is a posterior cerebral artery occlusion, the visual cortex, we have learned the visual cortex is over here and near the occipital pole. So that will be affected. That is, there will be contralateral homonymous hemianopia. There will be contralateral homonymous hemianopia, and we will be learning it later when we learn the visual pathway in detail. And along with this, there will be macular sparing. So there will be macular sparing. What is macular sparing? The macular vision is represented in the occipital pole. In the occipital pole, we get the macular vision. And occipital pole is supplied by posterior cerebral artery as well as an additional supply, that is, there is a collateral supply from the middle cerebral artery. So if there is only a posterior cerebral artery occlusion, the middle cerebral artery will supply the occipital pole. So there will be macular sparing in this condition. So this is how it is represented. If there is a left posterior cerebral artery occlusion, then there will be a right homonymous hemianopia along with macular sparing. So this is what happens when there is posterior cerebral artery occlusion. This is about the blood supply once we have learned the functional areas. Thank you.